Thank you. And thanks to Bitcoin Park for helping us, along with 1031 and Unchained, produce and co-sponsor this event. I've got to be really brief, and Rod did a great job of starting, but we're all here because we have an interest at the intersection of Bitcoin and health. Who here works in the health industry? As a provider? Okay, awesome. Or has an interest even in healthcare. The case for Bitcoin in healthcare, I need the slide advancer, don't I? Okay, awesome. Thank you, guys. I get the sobering duty of sharing some statistics that most of you have probably seen in some form or fashion, right? This is the current U.S. healthcare situation. 72% of U.S. adults are overweight or clinically obese. 3 in 4 have at least one chronic condition. 1 in 3 have what's called the metabolic syndrome, which is interrelated to things like diabetes and obesity. And the one here on the end, I think we all have recently become more sensitive to. Every 11 minutes, someone dies by suicide in our country. And we're seeing that more and more in our young people. We're sick as a country. And we do something called sick care, in my opinion, largely in response to healthcare crises rather than proactive. And I think that ethos is really our opportunity today. 5.3 trillion is the number now that we spend on healthcare annually. 5.3 trillion, it's about 18% of GDP. Again, we're the sickest in the developed world. So how in the hell did we get here? Right? Well, these are the big subject headers, right? Third-party payer system, right? We have totally disconnected the patient customer from the provider experience. That is a huge, huge part. We're going to talk how and why that happened. We have regulatory capture, right? We have coding and billing. We have an administrative waste layer in our healthcare system that's $800 billion. Honestly, I think it's more than that. And then probably the thing that we talk about most in this, in our space, is the incentive structure. Misaligned incentives, right? We are incentivized to use healthcare more, not less. And we should all be thinking about, actually, how can we use the healthcare system less? Because that's a huge signal that we're doing something right. Yes, we will need healthcare. As we age, we will need healthcare. Real quick story. I lost my father recently, who suffered with Parkinson's disease, right? He didn't expect that to happen. None of us did. But it happened, right? So we know we're going to need healthcare, especially as we age, but we have to be more intentional in how we access it. And then monetary debasement, right? That's where Bitcoin comes in, really, where we can think about a new money system, sound money, at the intersection of sound health. So the history, real quick. I'm sorry if I'm blocking the stage for some people. This all started in Dallas, Texas. For those of you in Texas, thank you so much. It was the Baylor health system, Dr. Rahimi, in 1929. The teachers union jumped into an offer from the Baylor health system. They were needing revenue. It was during the Depression. And so 1,300 school teachers in Baylor got 21 visits, hospital visits a year for $6. 50 cents a month in 1929. What a great deal, right? But it did two things, right? It caught on. Oh, how do I go back? It caught on. The American Health Association started branding this as Blue Cross. So Blue Cross originated from this exercise here. But two flaws were baked in from day one. They only paid for hospital stays, which drove the episode of care to the most expensive place imaginable, the hospital. And it further separated the patient from the true cost of care. But something else happened in the 1940s. World War II, right? There was a wage freeze because there was a shortage on workers. But someone had a great idea. Let's create health insurance tied to employment as a way to attract the best and brightest and to retain them. And that's exactly what happened. And from then on, your employer had your health plan for the most part, and today 160 million Americans still get their health insurance through their employer. And that's something that people like Andy Schoonover is trying to change at Crowd Health, right? And others, by the way. Again, we have no concept of what care truly costs. I'm going to share an infographic. And before we hit play, I'm going to step off for just a second. So what, does anybody know what this is, real quick? This is the grid of healthcare expenditures in the U.S. from 1960 to 2022. Andy, have you seen this graphic before? So I'm going to take you on a little history tour of about 62 years in 20 seconds. I want you to notice a few things. That top right number, 23 billion in 1960. And then I want you to look at the y-axis here in terms of where the dollars are spent. And the last thing I want you to really pay attention to, and because we're at Bitcoin Park, is the color orange. The color orange signifies the patient responsibility. So orange is pretty prevalent in 1960. And Jack, if you can hit play real quick, let's just watch what happens. Keep going. It gets better. That's what we're doing today, right? Yeah, so it gets worse. And this is only through 2022. So people may say, by the way, the green is CMS, 1965. July of 1965 was when the first Medicare payment was made. Isn't that great that the patient pays so much less now than they used to? It's not, because we have, again, patterned intermediaries in this system. So now we spend, this says 3.7 in 2022, it's over 5 trillion now, 3.7 trillion. And look what happened to all the orange. Wow. We'll make this available to people if you want to use this in any, it's publicly available and it's a great infographic. So as we move forward, well, let's go back to the, thank you guys. I'll step back up. So 56% out of pocket in 1960 we pay, now 11% in 2024. And what this doesn't take into account, it's somewhat represented, but it's not a category on the graph, are insurance premiums. It's represented in tax dollars through CMS because that's what subsidizes CMS in large part. And commercial insurance was featured in there, so we have healthcare premiums. But we're going to spend more as we move forward in the U.S., right? 800 billion, 30% of every healthcare dollar is overhead. We have zero visibility, and we have an insurance and coding platform that no one really understands. But look at all these intermediaries between the patient, customer, and the provider. I'm going to tell you a little story. How am I doing on time? Perfect. So I've been in the surgical device arena for over 20 years, working in neurosurgery and orthopedic spine. And what we do is we take a new technology, we go into markets, we identify surgeons and hospital systems that, in this case, and for most of my career, did a lot of spine surgery, which is one of the most expensive line items in the operating suite across this country. And this is how device companies form, for anybody that's not privy to this. A company will develop an implant. They will look at the existing CPT and DRG codes that are available, and they will optimize for that, okay? What I'm saying is, it's not like there's not great innovation. We do the best R&D and innovation in the developed world when it comes to surgical devices. But this is the one that I was a part of, okay? So we put these implants in. These are triangular porous plasma sprayed implants that were designed to be fixated across the SI joint. So if someone came in and with low back pain, they were refractory to conservative care, meaning they failed conservative management, through a small incision, our spine surgeons would tap these across the SI joint and lock it down. They listed for $5,000 a piece. We put 3 of them in each patient for $15,000. And some hospitals paid for that. Why in the world would they pay $15,000? And you're really going to freak out in a second when I tell you what they cost to machine. Why would they pay that? Because they have a DRG system that allows for that type of reimbursement. And when it goes to commercial insurance contracts with the BUCAs, BUCA meaning Blue Cross, United, Cigna, Aetna, a lot of those contracts are percent of billed charges, meaning the more they actually charge to the insurance carrier, the more they're going to get reimbursed. So they're actually incentivized to do more surgeries, to charge a lot of money because of those contracts. So companies like this will look at what's available, and they'll create a pricing structure. $5,000 per implant. We put 3 in. Guess how much one of these bad boys cost to machine? $50, $3. You guys are good. $83. Nice markup if you can get it, right? Again, we helped a lot of patients. Thousands, hundreds of thousands of patients. It's not an indictment on the R&D. It's an indictment on the system. What we're going to discuss today has nothing to do with politics. It is about behavior and math. And the math don't math, okay? So what would an open market look like, right? Well, LASIK eye surgery magically has come down 95% over its history. Why is that? It's all cash. You have to compete in a market. I'm not comparing LASIK eye surgery, by the way, to spine surgery or a complex cancer patient or a cardiac patient that requires a lot of management. But this is an open market, okay? Pretty simple and straightforward. DPC, we're going to talk a lot about that today, right? In Nashville, Tennessee, you can get a DPC clinician for $2,000, $1,500, $2,000 a year, right? It's a great model depending on the patient. And then Surgery Center of Oklahoma, probably one of our best examples of a surgical center in terms of cash pay. They publish all of their prices on their website. They've been in business over 20 years. They've had one price increase, one, coming out of COVID because of all the inflationary pressures. These are ways that we can think differently about how we do healthcare. Okay? So this is really sobering. I know, doom and gloom, right? It's going to get better, I promise. The average U.S. couple needs $330K a year starting at retirement just for healthcare costs, separate of Medicare subsidies, by the way. Who's prepared for that? Most people are woefully unprepared for that, right? Medicare Hospital Insurance Trust Fund depleted by 2033, 7 years from now. As John Gordon often says, Medicare's not going to be around to do my hips and knees, when I need them to. He's probably right. This is a great study, and I've got 3 minutes left. So Dr. Steven Schroeder, UCSF, probably foremost known for his work on smoking cessation and behavior modification, okay? He did a meta-analysis in 2007. This data was re-examined in 2024, same outcomes. What social determinants determine whether you and I are going to die early or not is basically what the study was sought out to show. Guess what? 40% behavior. Shocker, right? Behavior, our choices of what we eat, if we exercise, do we smoke, do we drink? Genetics, 30%. Healthcare, whoa, 10%. Wait a minute, we spend $5 trillion. Shouldn't this have an impact? This is representative of how we can do things better. What if we had different incentives, right? What if we could change them? What if we could build a more sovereign system that connected the patient and the provider? And it is our good friend, Dr. Mark Stephanie, has been telling me for the last 10 days, Stu, I'm sick and tired of defining the problem. Let's fix this. And he's ready. And we're going to hear from him and others today. And so I'm super excited about that. Does that surprise anybody, by the way? The behavior piece is pretty self-evident. But the healthcare piece, wow. So where does Bitcoin come in all this, right? There's a lot of crossover. We have low time preference, right? We have transparent direct pricing opportunities. Again, like what we're seeing with opportunities like Crowd Health. Value for value is where it comes down to, right? Value for value. We have dentists in this town. Dr. Link is going to be on a panel later who, I guess, accepted Bitcoin. Interested to hear about your previous experience. We have a dentist here in town that accepts Bitcoin. We have a lot of folks across the country that are accepting Bitcoin as payment, right, to eliminate the billing problem. And we have a fixed supply. We're just launched the first Bitcoin health savings account that allows you to hold actual Bitcoin in a self-directed, federally regulated account, triple tax advantaged. By the way, it's a great time to stack triple tax advantaged Bitcoin. I'm just saying. That's my shameless plug. But these are solutions that can help people arm themselves and their families for the future. And the young people in the room, like, this stuff's coming, right? It's going to come, and you're going to have to be prepared for it. How are you going to finance your health journey, right? Looking forward to all these panelists today. I want to say thank you again to the park and to all of you for being here. I'm very grateful for the time that we have. This is going to be the first of many events like this. I believe we have an opportunity to do something special as we continue the discussion of Bitcoin and healthcare. So thanks so much, and I will turn the mic over to Mr. Rodriguez. Thank you.